because at this point, with the exam, your exam's tomorrow, you would have at least have looked at the PowerPoint. So, and I'm going to go over possibilities. What might you see? What could be a question, right? So I will put up the PowerPoint. And then let's see what all we can do with this. So there's quite a few chapters, 25, 26, 27, 28, 29, 30, 31, 32. It's a bunch of stuff. You know, you're talking respiratory. You're talking questions on blood and the heart and skin and GI and metabolic. It's like so many stuff. How do you remember all of these things? Well, one of the things you need to know is your definitions, and they're all sitting right here. So let's go look at coryza, common cold, right? Easy. Common cold, me and you. It's not allergies. It's that little bit of fever, right? The little bit of cough. Now, when we do respiratory, you got to think of respiratory distress. What are signs that are telling you it's just not a common cold? I'm in trouble. So they're here. Why are you tachypnic? You're breathing fast, right? That's all because your lungs aren't working. They're occupied in space, right? There's junk, there's rails, there's wheezing, there's rhonchi, and you're breathing fast, trying to get oxygen around, right? That's the big thing. Now, of course, it's going to be seeing, retractions, increased use of accessory muscles. That'd be one thing. And then, of course, as we get more into distress, you're going to see cyanosis, usually in the fingertips, the nail beds. And because why do you think you get irritable or confused in respiratory distress? Why would you think that?
Less oxygen in your brain.
Lack
Lack
of
of oxygen.
oxygen.
Right. Because your heart's trying really hard to keep up with it, but it can't because you don't have all that space collecting all that oxygen on each breath. So yes, very good. Normal O2 sat on a child. You want it
90
above 90. Yeah, 90. Now, if it was 89, we do something simple, maybe a cannula or something. But 90 we consider okay, unless your condition of that patient doesn't look good, right? So it's always everything is on patient condition. So tachypnea, breathing fast, coryza, common cold, and atelectasis is what we get when we don't do coughing and deep breathing postoperatively. Those little alveoli collapse. And then what happens? You're not collecting oxygen because that's where it happens. What carries the oxygen is your erythrocytes. That's why we need a good hemoglobin and hematocrit, because it carries them around. All right. Common colds, respiratory things, pharyngitis. Now, this sore throat is not a viral cold. I don't feel great, but it's, I think, more of my rheumatoid arthritis, which is causing swelling. So any swelling, irritation, inflammation of your airway will cause this sound, this squeaky sound, or even respiratory distress. So your sore throats can be viral or they can be bacterial. Remember, a strep throat is a big deal. Look what it causes. Rheumatic fever, which is, it can affect your heart valves. Glomerulonephritis, it can attack your kidneys, stop you from urinating. It can cause your tonsils to get big. And I'm telling you, a peritonsillar abscess, you smell. They're bad. And of course, anything goes up into the airways, up into the to the ears, through the eustachian tubes, goes into the mastoid glands. And where is the brain? Where is it connected there, right? Meningitis, and you do have bones. You have sinus bones. That's your osteomyelitis. And then again, you can swallow it. Very important. Now, always with anything where you have a fever, remember you're losing fluid. Make sure that we replace it. Small, frequent sips. Don't overwhelm the child with a big chugga, chugga, chugga. Okay? Bronchiolitis is another word for RSV. So if you see RSV or bronchiolitis, it's the same thing. What do we see with it? Well, the most common pathogen is viral. We know it. And what the ones that we're more concerned about is your younger children, 6 months to about 2. Why? Well, what does it do? It collects mucus. Can you breathe? No. An infant, suck, swallowing, breathing, even at 6 months is pretty hard. So RSV in some children can really cause harm, especially if they have another comorbidity, like a cardiac condition, right? Asthma. What you need to know is that this is the most common of all respiratory things that keep kid out of school. They go to the ER and they go to the hospital. It's just one of the most common things. LTB, laryngeal tracheal bronchitis. This is croup. What do we know about croup? Well, it's an inflammation in the epiglottis and the airway, and it causes that airway to go into the larynx, gets really swollen, and a little bit is occluded, so you can't breathe. That's why you have stridor, that as you breathe, and you would hear that high pitched. If croup is left to continue, it's still a virus, it's an H influenza, but it is life threatening. And why is that? Well, this is when it swells up all over. It's like putting a lid on your trachea. Now air can't get in. So now it's all airway. And what's the one thing priority all the time? Airway, airway, airway. Cystic fibrosis. This is all about um, thick secretions in the lungs. It causes infertility because in males, it clogs the semen in the vas deferens and it can't come out. So the sperm doesn't reach the woman and they're infertile because of it. But 1 year post bilateral transplant, lung transplant, they can get their woman pregnant. And many men do that just to have a baby with their partner. Remember, cystic is not just to do with lungs. It's all about digesting foods, nutrition, right? So we don't absorb fat. Well, knowing nutrition is important and you don't absorb fat, it's being lost, and your stools are bulky and they stink beyond foul smelling. It is, put a mask on because the smell, I'm serious, it is that bad. Now, fat goes away. What are you left with? How can you supply nutrition? Protein, right? And carbohydrates. Now, one of the things in cystic fibrosis and how we diagnose it is by looking for salt that's excreted through the skin. And you're going to see really high levels of salt. So you're losing salt like crazy. So that is the electrolyte that we're concerned about, sodium. These children, give them the salt shaker. They need it. So it's respiratory, thick secretions, and it's also nutrition because they're losing fat and they're losing sodium. Now, cardiac has a bunch of different types of definitions too. So these are things that you're going to have to go through and just memorize. That's all there is to it. Is there any diagnosis here that you need better explanation of? Too fast, too slow, difficult, thickened muscle don't work good, hypoplastic. Shunt goes from this side to that side. And I've always said in a shunt, it always goes from high pressure and it wants to escape where it can. So if there's no pressure over there, that's the way it's going. So that's shunting. Just like the mucus in the oral airway. When there's mucus, it wants to go somewhere, it goes into the ears through eustachian tubes. It's a shunt, but not like a cardiac, but very similar to that concept. Murmur is those sounds. We hear them a lot when there's holes between the two sides of the heart, whether it's atrial septal defect, that means that septum in the middle, it's not complete. There's a hole, and you hear a bam, bam. Also, ventricular septal defect, most common of all of the murmurs, and that's a hole between them. And this one is really a hole, and you can feel them on, putting your hands on the chest. Tamara, did you need something?
Yes. So I have a question about the ventricle defect and the atrial defect.
Uh,
So I wanted to know, does both does both transfer blood to the lungs or oxygen to the lungs?
well, oxygen goes to the lungs, but it allows an area for the left side to push it back to the right side and it goes back to the lungs again. So it's actually doubly oxygenated. So your O2 saturations are always normal.
Okay.
Did that answer your question?
Yes.
Because remember, that right side blood just gets back in there, just crawls into the right side. And if you have a hole, all of the blood is flowing from the lungs down to the left side. It pushes it back over. And then where does the right side go? To the lungs. So it will recirculate again and again. That was a great question and what a very difficult concept. So thank you.
Thank
Again,
you.
ASD, VSD, how do we take care of it? Well, many times we let these children grow out of it. Many times it can't grow out of it, it's too big. So we might do surgery. Or actually, where I'm from, I'm going to tell you something that's not on the exam, but just for your information. Dr. Burke developed what we call a helix device. And through cardiac cath, he puts it up into the heart. And it's like two plates. And he puts one side on this side of the hole and one on the other. And it prevents blood from going back and forth instead of doing surgery. And that is, as actually was seen on Good Morning America when it first came out. It was one of those innovative things. And as I said in nursing, you're going to see so many changes and so much stuff that does we give better and better care to our patients and then to ourselves as we grow older. Same thing with VSD. Left side, it will go to the right side only because the left is pushing it back to the right, back into the lungs. Patent ductus arteriosus is fetal circulation. It connects the lungs to the body, pulmonary artery to the aorta, so lungs to the body. So it's extra oxygen going around. Coarctation of the aorta is a kink in the hose. And the way we're going to diagnose this is through an aortogram. And what that is they put dye into the aorta and they look at where the kink or narrowing or where blood doesn't go through. And they need to go in and either open it in a cardiac cath or remove that piece that's really tight and blood can't flow. The coarctation of the aorta, there's a couple things about it. If you don't get blood going down because it's kinked, it only can go backwards. And it's going to cause congestive heart failure because it goes back, area of least resistance is the lungs fill up. It's just what it does. And the lower extremities doesn't have much of a blood pressure at all, not a lot of blood. So lower blood pressure's down and higher when they're on the top. Tetralogy is your tet spell. This is the one that we call the blue baby, right? All of a sudden they turn blue. I've seen O2 sats go from 100 to 10, like in minutes. And this is the knee chest. We squat when we're older. So that's what you need to know. Most common of all cyanotic diseases. What would you see if you saw a child who, let's say, with that tetralogy of Fallot or the coarctation of the aorta, blood is going back, sitting in the lungs, and I said it causes congestive heart failure. What are signs and symptoms of congestive heart failure? Well, blood is filling up in the lungs. So they're going to have a sudden weight gain because the blood is sticking up there, pooling, because it can't get down through the kidneys and be filtered. Okay. Also, they're going to be tachycardic, they're going to be dyspneic because the oxygen is not getting what they need. Blood is covering those areas where the exchange is done. So, signs of congestive failure, sudden weight gain, tachycardia, and dyspnea. Hypoplastic left heart, left ventricle doesn't work. So, this is the most serious of all surgeries. How do we diagnose cardiac problems? Well, I've already told you about the aortogram. Echocardiogram is just like what we do when we have a baby. And that echocardiogram will look at the blood flow and find things what's going on. There we are, congestive heart failure again. What would you see? And then complications that can occur. Well, if you have all this fluid, because your heart's not working, blood is pooling in the lungs, you're going to have pneumonia. Rheumatic fever. This is due to strep infection, right? So we got to be worried about giving penicillin. And remember, they're going to be given penicillin for 5 years prophylactically with this one to take care of that heart. And again, it goes, this strep goes into the brain, goes into the kidneys, and into the ears. Meningitis, glomerulonephritis, otitis. So again, congestive heart failure, we've gone over a lot of them, but what do we have to be concerned about? Our biggest concern is nutrition, right? So we're going to do very small feedings, only 30 minutes, and we're going to be doing care on like we call cluster care. So we don't always bother them, right? And making sure we're monitoring that weight, the intake, the output, the daily weight, because this is a fluid problem. Congestive heart failure is too much fluid where it shouldn't be. So we're going to be watching that. Rheumatic fever, as I said, is due to strep. We're going to give penicillin and we're going to do prophylaxis for 5 years. And it does help. And if the heart's already damaged, it's damaged. We can't do anything. But if we catch it quick enough, we can turn everything around. We're going to use the NSAIDs, anti-inflammatories, steroids, and the aspirin is used to prevent clotting in this case. Hypertension, kids do get high blood pressure. Years ago, we didn't check it all the time, but it's just a regular diet we would give to an adult. We would give them low fat fruits, vegetables, fish, poultry, and low sodium. Sounds familiar, doesn't it? And remember, blood pressures on children can be measured in the arms, the legs. Get it where the kid's comfortable so you get an accurate reading. They also get what we call hyperlipidemia. Hyperlipidemia when there's too much fat in the blood, right? So LDL, as I call them, cholesterol, lousy cholesterols. Yvette, did you try to get a hold of me?
Yeah, the hypertension that can be from like obesity and hyperlipidemia from obesity, right? In children?
It can be, absolutely. It's
Okay.
it's the same as adults as it is in children. The same, and the medications we use, same in children that we use in adults. It's just milligrams or micrograms per kilogram per dose per day. Yes, very good. Absolutely.
Thank you.
HDL is healthy cholesterol, and it's what we want. We need fat, but like with the DASH diet, we just need it in minimal. We don't need as much. Blood disorders, iron deficient anemia, most common of all of them, right? And what's the problem when you don't have enough red blood cells in the body? What do red blood cells do again? Red blood cells.
Carries oxygen.
Carry oxygen and iron, food to the
Right.
cells.
So if you don't get iron, which is the food, you don't get oxygen, which gives them energy, this child's going to be really down, really tired all the time, right? So we know that anemia, there's all different types of them, and we're going to go into some of that. Iron deficient anemia, when do we see these things? Well, iron deficient anemia, we're going to see a lot in toddlers that are placed on whole milk because now they're not getting the iron in their formula or breast milk, which carries it with vitamin D we give them too. So, and they're picky eaters. Very common for a toddler to have iron deficient anemia. We need to give many times iron supplements now. Never ever give iron supplements with milk. It coats the stomach and it needs stomach acids in order to break it down. You don't have stomach acids, it doesn't get broke down, it's not used. So, what's the best way to give it? With what liquid? Orange juice. Because it's another acid, okay? Very important there. Hemophilia, you bleed, your blood doesn't clot. Another definition, hyperlipidemia is just excess of fat in the body. Sickle cell is hereditary. It comes from mom and dad given to the child where the cells clunk up and can't get through the vessels. One of the things that we give these children and we maintain and tell them to do on a daily basis is to hydrate, keep the vessels big so that the blood can flow through. And we'll be giving pain medicine when they have a crisis and we'll give them oxygen. Erythropoietin. Now, sickle cell anemia, and the reason why erythropoietin is here right now, thalassemia and sickle cell, both the cells, red blood cells, die quickly, very quickly. So hemoglobins are always down. So in order to keep up red blood cells, which is oxygen and iron, which you know we need, I've said it 3 times already, we'll give them erythropoietin. Usually the kidneys do it, but we're going to give them an extra boost. And it's usually sub-Q, and depending on it, once a week, once a day, it all depends on the physician and the patient. Thalassemia is another blood disorder inherited, but this is when the cells burst and they just don't work. But the problem with it is they spew out iron and oxygen. So they're always tired, right? Their blood cells are always low. They have to live on blood transfusions. So they get a high H and then it goes low because it dies. And then they get blood transfusion, it goes up. This causes heart failure, okay, in these children. And all that bursting of cells causes that jaundice. Leukemia, white blood cells don't work. They're just immature, don't work. Now, what do we need to know about leukemia? Well, in leukemia, we know that these children are very apt for infections. So we need to be careful with no immunizations of live, vaccines like chickenpox, the varicella. That'd be one you wouldn't. Um, if they're exposed, let's say they're exposed to a person with COVID or influenza, we need to tell the doctor because they'll get very sick very quickly. There's no immune system. They get mouth gets ulcers, they don't feel like eating, so give them whatever they want to eat. If their favorite food is a cheeseburger from McDonald's, get them that cheeseburger from McDonald's. You need to get the nutrition in there. Good oral care, right? And one of the things about leukemia, these kids are scared. They have that big C word, and you need to let them talk. Okay, GI, GU, abdomen. What do we need to know? Well, we know GI, mouth to anus. So dysphagia is difficulty swallowing. One of the GI problems and meds given to children regularly is acetaminophen. We have to be careful and I always tell parents to write down if a child's sick for a period of time and more than one person's taking care of that child, write down the medications they gave and the date and time so that they don't overdose these children because it causes, liver problems. It can really cause toxicity. Big thing about GI is that fluid electrolyte, vomiting, diarrhea. So we've got to understand signs and symptoms of dehydration and how to replace it. Pyloric stenosis, 3 months, 3 weeks to 3 months. Pyloric stenosis is projectile vomiting. Mecyldiverticulum is the small intestines, and you're going to see bleeding on this because this little skin tab, this diverticuli rips, and inside is a big blood vessel. So it just drips blood, but it doesn't hurt, but you need surgery to take care of it. Appendicitis, the big thing is right lower quadrant pain rebound. It needs surgery. We'll diagnose it with an ultrasound. And one of the things we'll be watching with these children is inflammatory factors and then those white blood cells, right? If those white blood cells start going up, we know there's a leak. And we know that this child probably has peritonitis, right? So one of the concerns, watch that. With appendicitis, monitoring their vitals, checking for their pain, absolutely. And then if they don't have pain, they'll be up, they'll be out, they'll be walking, coughing, deep breathing, preventing side effects. And we'll start with clear liquids on these children to work up. Hirschsprung's is when there's a piece of bowel that does not function right. And we'll do either a colostomy and close it later, removing that piece. And we call a pull through, where we just take out the piece and then connect it right to the anus. But there's some sort of intestinal surgery that will be done because that piece of intestines doesn't have nerves, it doesn't work. One of the things with GI, I told you, is the vomiting diarrhea. And there's reasons why. You could have in diarrhea, you ate something and your tummy didn't like it, and that's a food intolerance. I know if I eat bananas or corn, I'm going to be in trouble. And it's just something I've learned with me. We think that infants, they cry, we have to just stick a bottle back in their mouth. So a lot of times we overfeed them. That can cause it. What about not having the proper water if you're mixing it with powder for your formula? That can cause problems. And then this sorbitol, which could be part of the formula, etc. So what's our priority problem with diarrhea? you're losing fluids. You're losing alkaline fluids, right? Because all your digestive stuff is alkaline. So you're left with metabolic acidosis. And we need to start giving them their fluids back, checking electrolytes, making sure they get it. Now, how do you know after 2, 3 days in a hospital that that child's improved besides the diarrhea has stopped? Remember, anything with fluid balance, intake, output, daily weights. What was the weight when they came into the hospital? Probably lower. Now that we've replaced that fluid, guess what? That weight's going to be more. That is our telltale sign that a child is getting better, with vomiting, diarrhea, anything that you're losing fluids. Celiac disease is an intolerance to gluten, so don't eat it. A good choice to replace would be rice. So that's what they recommend. These children, they have a problem again with fat. So you need to increase proteins and carbohydrates and veggies, fruit, beans, rice, nuts, even dairy, legumes. All of these things can help them. Strangulated or incarcerated, what are you going to see? Pain. I mean, think about that belly button. You can stick your finger out and squish it, and they're fun to play with, right? The umbilical hernias, I think they're fun. What if you touch it and the kid's in pain? That is an emergency. We need to figure out. It's twisted, it's dying. You're going to end up with a perf and peritonitis if we don't fix that quickly. Again, glomerulonephritis is due to strep. And then constipation, common in kids. It could be an emotional thing or just diet. How do we treat it the best way? Well, we don't give enemas. We don't like giving laxatives. So we do it the natural way. Raw fruits, raw vegetables, and high fiber. Don't cook them. They need to be raw. They need it that way. GU, this is all about those children who has problems, with urinary tract infections. And a lot of time these are girls. And it's sitting in baths and bubble baths. This is wearing those cute pants that are tight. Don't let the perineal area breathe and wiping the wrong way. So no bubble baths. Make sure they're drinking plenty of fluids and cotton underwear because it can breathe down there. That's why that. And they actually say white ones are the best. Hypospadias, instead of the openings on the end of the penis, is underneath somewhere. And epispadias is actually on top. It's not one of your definitions here. Cryptorchidism is the testicles. One doesn't come down or both. That's why pediatricians check the testicles on the first visit. And then skin. There's all kids and their skin and rashes. I think this is the most difficult for most physicians to diagnose because there's so many different variations. Now, impetigo is contagious as heck. My grandson had it. And it's oozy, juicy, painful. And he had it behind his knee. So every time he walked, it would pull and it would stretch and crack. And it would be goopy. It's a staph infection. Oral topical antibiotics. Ringworm is not a worm. It's a fungus. And you just see a round area on the skin, usually red and round and itchy. Pediculosis is going to be head, body, or pubic lice. And eczema. We worry about eczema and that liquidation, whatever that word is, about that thick skin that occurs from chronic itching, chronic eczema, almost like leather skin they get. Scabies, we give lotion. Remember, scabies, it needs to be applied overnight, 8 hours minimum. That's how it works. So what we do is we apply it at night, let them sleep. In the morning, we'll wash them, and then, of course, change the bed sheets, put the other toys that we can't wash in baggies for a week or so that all the eggs and everything can die. And then there's burns on these children, the rule of 9 and hydrating. Again, there's scurvy.
So I'm
Yes,
sorry. We
go
treat
ahead.
scabies like life, basically.
Basically,
Okay.
overnight, 8 hours is what that needs to be on there for. And just like scabies, if one kid has it, you better look at the whole family because the whole family could have it. Because remember, there's blankets and couches and stuff that has cloth and they can jump on and then jump on you. So everything. And there they are, the washable toys. It's in those like Ziploc bags for a week. Burns, be careful with children. They like to pull handles, pot handles off the side of a stove. One of my brothers, my second oldest brother, he pulled a boiling water off the stove and he just burned his right arm and he had this huge scar. And it was because he was doing that. So always safety, always remember burns, always remember safety. Another thing, if there's a burn and it's anywhere in the upper air, chest, be careful. They could have inhaled it. And now you've got an airway which will swell. And now you're not going to have an airway because it's swelled up. Okay. So in burns, be careful of airway and also be careful of safety things, child proofing things, pulling cords, pots off stove, those things. We always will do fluid resuscitation with burns because that burn has basically burnt the skin and all the moisture. So again, how do you monitor any fluid balance? Intake, output, daily weights. And then of course, lab values, looking at sodium, looking at potassium, absolutely will be part of it. And we can also look, is the lips moist, is the tongue moist, etc. Eczema, again, this is looking at the sensitivity of the skin, and that's the word that I was absolutely torturing. Lichenification. It's those thick, leather-like looking things, something that we need to look at before we treat. It will affect how we treat those children. And eczema itches. So making sure that we give the hydration. In a lot of these skin conditions, one of the first thing is that hydrating it and then placing whatever medicine on it. With acne, make sure that, adolescents, I've got acne, and then they wash their face 28 times a day. That's absolutely what we shouldn't do. So not over doing it because it mixes, actually the body will produce more oil. So keeping greasy hair stuff, a lot of times your hair is dry, you like grease on it to put whatever style you want. Again, that can get on the skin and create it. And we know there's all different stuffs there. And the adolescents, which is when this all happens, they need to know exactly what's going on. Metabolic, thyroid, diabetes. Thyroid condition is just like adults, but what is the difference? Well, we need the thyroid hormone to grow. Adults, you've already grown up. Also, it needs it for their mental cognition. Infants born that have hypothyroidism that are not treated, usually there's two things that you will see in the first month or two that will bring you aware. One is constipation, and the second one is they're not where they should be on their growth and development. So those are two things you look at. As we go further, it would be, it's fine motor, gross motor skills, right? As we go further, we're going to see them not gaining weight and growing the way they should. Diabetes, most likely in your younger kids, is type 1. Type 2 is usually your older kids, and that is your overweight kids, Yvette. Absolutely. And that would be type 2, and they'll get type 2 medications oral. But type 1, when they are young, the insulin's not working, the pancreas is not working well. They're going to need insulin for life, okay? In type 2, if it's due to that overweight, sedentary health, they're going to change that, change their diet, put some exercise. They can stop this type 2 diabetes just from being healthy. What do you see with diabetes mellitus? Symptoms, signs and symptoms. And I've seen little 2-year-olds come in. I still remember in my mind this blonde-haired, blue-eyed little girl. She came in, she was thirsty, she was urinating a lot and hungry, and had lost 10 pounds in the last 2 weeks. 10 pounds on a 2-year-old, and looked very pale. And that brought her into the doctor, and her blood sugar was over 600. So they do not look really good until we get their blood sugars down. And another symptom is they're urinating at night, enuresis, nocturia. So polyphagia, polyuria, polydipsia, weight loss, and then, being incontinent at night when they're already potty trained. Low blood sugar. What do you see? And what do you do? Well, they'll be irritable, sweating, hungry, weak. They can be a little confused. And sometimes they get a little bit wobbly and fall over type thing. Now, what's the treatment? It's not the same for them all. If they're awake and alert, I'll give them some honey if they're old enough, right? Some sugar, give them something, get it up. But if they are unconscious, don't try to feed them anything. That would be glucagon, and that will raise their blood sugars quick. Diabetic ketoacidosis is hyperglycemia with ketonuria. What happens very simply? The body doesn't digest sugar, so sugar stays in the body, and it oozes sugar out of their pores and their breath, so they smell fruity and sweet because of all of that high sugars, all right? And then you test their urine and it's full of ketones because they're not having sugar. It doesn't digest, so the body eats proteins and fats, and the side effects is ketones. As nurses, we need to teach our parents and children on how to travel because they're going to travel. Now, insulin does need to be refrigerated. So making sure they have it in a little pack with little ice packs in there to keep it cool. And when they get to where they're going, put it into the refrigerator. Making sure they have everything they need, and also researching, is there a hospital around where I'm going in case of any emergency? I mean, would you go to somewhere where there was no hospital anywhere with a child with diabetes? Not really, because you still need to make sure they're taken care of. Cushing is too much cortisol. This is too much steroids. And what do you see with this? Well, many times these children, big round moon faces, these red ruddy cheeks, they call it. And you'll see them because remember Cushing syndrome, there's going to be what we call protein wasting in it. So your muscles are going to be thin and really not normal size. So you're going to have skinny arms, thin legs, but the body, the trunk, the neck is all going to be big and pudgy. Okay? Diabetes insipidus has nothing to do with blood sugars. But look, it's two of the P's, polyuria, polydipsia. Now, nothing to do with being hungry, nothing to do with blood sugars. It's the pituitary gland that secretes this too much diuretic hormone. And you're urinating. Well, what happens when you lose a lot of fluids? Well, you could be dehydrated, can't you? And you're going to be losing all of the electrolytes like potassium. So your priority is to check for dehydration, assess their vital signs, elevated heart rate at rest, decreased blood pressure, and keep going. You're going to see now these children are urinating, so you can't look at decreased urine output with this dehydration. Mostly it's elevated heart rate and decreased blood pressure. And then immunity. What am I born with? Or the acquired that either you have the disease or you've gotten that vaccine against it. Active immunity, make your own. And then passive is you give them something, it works for a while, and then it's gone. Now, there are dosage calculation questions. I want you to be aware, don't get nervous when you see units on a question with dosage calc. If you don't like that label, make it milligrams, okay? Because sometimes that units will just, I don't know what that means. Well, you don't really have to. Make it what you like, okay? Just remember that you have to have the same thing that you're giving, what dose you're giving, and the same thing in the medicine. So milligrams and milligrams, not grams and milligrams. Always make sure when you're done figuring out that question, did we want it per day or did we want it per dose? Now, there is a little refresher down here video. It's a very short one in case you need it. So I hope this helps you all. I hope it helps you understand more. I'm really glad that you all were able to come. And I expect only the best from you tomorrow. Tomorrow, do you need me?
Yes, I had a question. Did we already talk about, well, will hyperliteration be on the exam tomorrow?
What's the name?
I think it was like hyperliteration, or I might be saying it wrong.
Hyperlipidemia.
The skin?
Say it one more time.
The one with the skin? Is that what you're saying?
Possibly. It was like, oh, I don't have my PowerPoint pulled up. Hang on, give me 1 second.
Sure, take your time.